Welcome to Caregiver SOS On Air, presented by the WellMed Charitable Foundation, with nationally known gerontologist Carol Zernial and award-winning veteran broadcaster Ron Aaron. This program provides health, wellness, and other information for caregivers who are vital to the health and well-being of so many people across our country. And now, here are your hosts, Ron Aaron and Carol Zernial.
Well, hello, everybody, and welcome to the award-winning Caregiver SOS On Air. I'm Ron Aaron, along with our co-host, Carol Zernial. Carol has a master's degree in social gerontology, some 30 years experience in the field. She's co-chair of the Raise Family Caregiving Advisory Council and executive director of the WellMed Charitable Foundation. And in just a moment, we're going to welcome Dr. Thomas Weiss into our program. And we're talking about a topic that is very near and dear to the heart of a lot of people, Carol, and that's how to identify and manage, from a caregiver standpoint, early onset dementia.
Well, it's a great question because so many times it's hard to find out you have early onset dementia. That's, if you can get that far, that's going to be, 50% of the game. But the rest of it is very difficult because it's sort of out of sync, right? Other people of other ages are expected to get Alzheimer's, but early onset really makes the family, I think, the whole family suffer more.
Let's welcome Dr. Thomas Weiss. He's a geriatric psychiatrist in private practice. He's a graduate of the United States Air Force Academy, UT Health Science Center Medical School, and completed a fellowship in consultative psychiatry at MGH Harvard. Dr. Weiss is board certified in 4 specialties: adult, geriatric, addiction, and consultation psychiatry. And Dr. Weiss, thanks for joining us on Caregiver SOS On Air.
My pleasure. Thanks for the lovely invitation.
Tell us what your interest was in taking a look at early onset dementia.
So I think it's twofold. Like a lot of things in life, one is it's personal. I'm from a small German family. My mother passed away from Alzheimer's dementia at the age of 73. My father passed away of Alzheimer's at the age of 80, and my sister passed away at the age of, my father was 90. My sister passed away from the disease at age 80. So I had kind of a personal interest in it that's probably minimizing it. As an adult psychiatrist, as I got older in my practice of 44 years, probably the last 10 years, I somehow gravitated, maybe it was the hand of God, to seeing older patients. I just found them fascinating, their life histories, and seeing folks that had been partners for 55 years, 60 years, and now one of the partners is really starting to decline, and trying to kind of help with that suffering for both the patient and their spouse or the caregiver. So I guess it's kind of a mix of personal and then also the way my practice evolved.
Well, for those that don't know, when you say early onset Alzheimer's, what are you talking about?
Yeah. So, this is a disease worldwide. Maybe I should say it's an epidemic worldwide, where the 2 biggest risk factors are aging and genetics. And of course, we all would like to live as long as we can, as well as we can. But we know that with Alzheimer's dementia, it's a disease that generally starts perhaps sometimes in the late 50s, certainly in the 60s. And then in the 70s, it really takes off kind of like a rocket ship. Alzheimer's dementia is the largest capture area for dementing illnesses. We think probably 60%. There are 3 other common types of Alzheimer's that take a different form. One is called vascular dementia. That usually presents again in the late 60s, early 70s. And then there are other dementias that are less rare, thank goodness, because they're pretty aggressive and pretty difficult to treat. But they present when folks are young. One is frontotemporal dementia. It typically presents when people are in their 50s. And it doesn't present with memory loss. What it presents with is, out of the blue, dramatic behavior changes. often with hallucinations. Quite often, these poor souls are directed to a psychiatric unit to treat their hallucinations or their odd, um, inappropriate public behavior until the diagnosis is more accurately made by imaging and blood-based samples. Now, that's been a great leap forward in the illness. We can now measure specific types of dementia through a blood-based marker as opposed to the bad old days, believe it or not, probably 30 years ago, the way we would officially diagnose Alzheimer's dementia was with a brain biopsy. I don't know anybody that wants to volunteer for that. Then we got a little more skillful and we diagnosed Alzheimer's dementia with imaging and with lumbar punctures. Those aren't any fun, and as we get older, our spine gets pretty rocky. But now we have a blood-based marker. You just draw one's blood, and we're able to. It's pretty sensitive and pretty specific, specifically for Alzheimer's dementia. But as I say this, the other dementias that I kind of hinted at earlier, and I'm sorry I got off track. You wanted early onset dementia. The biggest one is frontotemporal. There's another one called Jakob-Creutzfeldt disease. This is actually transmissible if you happen to handle the material from a patient with that. That presents in an early onset too. And by early onset, late 40s, early 50s. And then there's a disease called dementia of Parkinson's disease. Typically, Parkinson's disease, the movement disorder, presents first, and then a couple years later, the dementing process, meaning, progressive neurodegeneration of the brain in terms of memory, attention, being able to have what's called executive functioning, problem solve. How you got to work today, you had to figure out where Loop 1604 was blocked off and where the floods are and take an alternate route. So in terms of early dementia, the good news is they're far rarer, but they're also trickier to diagnose because initially they look like a completely different disease. Probably frontotemporal dementia truly looks like a different disease. If I have 1 minute, I'll give you a little historical piece.
All right, hold that thought. I'll come right back to you.
Okay.
I'll give you that 1 minute in a minute. You're listening to the award-winning Caregiver SOS On Air. I'm Ron Aaron with our co-host, Carol Zernial. We're talking with psychiatrist Tom Weiss, talking about early onset dementia, and we're getting an excellent overview on what that is all about. So here's your minute, Dr. Weiss. Pick it up from there.
Good. So this is a historical piece. Back in 1846, there was a railway foreman named Phineas Gage. He was a nice guy. His employees liked him. They were building a railroad track. He was tamping down an explosive with a 3-foot crowbar. The explosion went off. It drove the crowbar through his chin and out the top of his head, blew a hole in his skull. Believe it or not, in 1846, he survived. They just packed some clothes around his head wound, took him into town. He was comatose for a couple days. The town doctor treated him with whatever they had in 1846. He slowly recovered, could walk and talk. But the dramatic thing was he had an injury to his frontal and temporal lobes. Frontal lobes control our behavior. They're what makes us stop at that red light at 3 a.m. Even though there's no traffic, our frontal lobes inhibit us. So Phineas Gage, prior to this accident, nice guy, excellent worker, wonderful foreman. He now became a raging tyrant, very profane. People avoided him like the plague. He was a different human being because he had a frontotemporal injury. The really wild part is he lived for another 15 years. And it kind of taught us that even though people can have a severe head injury, they can still survive. Prior to Phineas Gage, it was thought to be a goner. So that's a historical piece that you probably didn't want to hear, but it talks about a dramatic change in behavior from a frontotemporal injury.
Well, I think what you said is so important because behavior change is not normal. A lot of people think, oh, that's just getting old. Behavior change that's dramatically different. Oh, they just got old. But behavior change, a change in personality is not normal aging.
You're correct. And I think that's where the rubber meets the road in terms of, I'll back up to Alzheimer's dementia, although I know you want early onset. So Alzheimer's dementia is, I'll give you the fancy lingo, it's a progressive neurodegenerative disease that affects the four A's. So I'll speak a little medicalese: aphasia, apraxia, agnosia, and amnesia. Amnesia being progressive memory loss. Apraxia is how we move, like button our shirt, zip our zipper. Aphasia is speech. In other words, we forget language, words, how to communicate. Let's see, apraxia, aphasia, oh, and amnesia. Our memory slowly but surely dissolves. And here's the thing that really grabs me. When I talk with groups, I start with a kind of a provocative question. Is there anything more valuable to you than your brain? And then I kind of follow up with, if you think about living our life, lucky people that we really live our life to create memories. And now we have this disorder that slowly but surely dissolves all those memories. It's just disintegration. And it's over, we think from diagnosis to death with Alzheimer's dementia, maybe 8 to 20 years. I've seen some people go a little longer. Seen some people move through it real quick. But it's a progressive process. Same with the early onsets. They aren't going to be lickety-split in months. They're going to take some years before people pass. So this is a very cruel illness, and it robs us, and it scares us, scares the heck out of us because we know that it's transmitted by age. So the older we get, we're kind of looking over our shoulder, and it's passed on by genetics. Trust me, I've looked at my genetics, and unfortunately, I got dealt the wrong cards. So I'm just trying to keep one step ahead of the demon here, for lack of a better way to put it. Let me pause. I'm starting to rant and rave.
Well, no,
Forgive me.
no. When you come, we're going to take a break.
Yeah.
But when we come back, let's talk about sort of the impact on the family. You were talking about how cruel the disease is. Let's talk about what we can do about it.
How the caregiver can handle it. You're listening to Caregiver SOS On Air. I'm Ron Aaron. Carol Zernial, our co-host, is here, and we're talking with psychiatrist Dr. Thomas Weiss, talking about early onset dementia and caregiving. We're also going to touch on the subject of loneliness, which fits tangentially into all of this. This is Caregiver SOS On Air.
Well, thank you so much for listening to Caregiver SOS On Air. We're delighted to have you with us. We come to you every week with a discussion of an issue, a problem, some accomplishments involved in caregiving with more than 60 million caregivers across this country, but most thinking they are the Lone Rangers. We try to bring you the latest information and help that can make that job easier and more manageable. Caregiver SOS On Air takes a look at trends across this country. We provide tips on how to be a better caregiver, and most importantly, where you can go for help. On Caregiver SOS On Air, we try to give you what you need to make that caregiving manageable and to provide you with the help that can make your life easier. I'm Ron Aaron. Carol Zernial and I are delighted to co-host this program, and we're thrilled you've joined us on the award-winning Caregiver SOS On Air podcasts available everywhere, brought to you by WellMed Charitable Foundation.
Hello, friend. Hello, friend. Really good to see you once again. Hello, friend. Hello, friend. Really good to see you once again.
Well, thank you so much for staying with us right here on the award-winning Caregiver SOS On Air. Our podcast available wherever you listen to your podcast. We're also on the radio in several cities in Texas and Florida as well. Just Google Caregiver SOS On Air. We're talking with Dr. Tom Weiss. He's a psychiatrist and spends a lot of his time working with patients of late who have early onset dementia. And from the standpoint, Dr. Weiss, of caregivers, what can you do as a caregiver to interact with that patient?
Golly, my first response would be, how long do we have? But I know exactly how long we have. I used to think that the hardest job in the world was being a single parent. But now I think that maybe the hardest job in the world is being a caregiver. Because as I mentioned earlier, you're watching someone you dearly love dissolve, disappear. Um, and so what can a caregiver do? So I'm going to offer some medical aphorisms. In medical training, when you're on the cardiac floor, they say the first pulse you should take in a code blue is yours. In other words, do not panic. I like the message from World War II Londoners during the Blitz, keep calm and carry on. But it's easier said than done. Easier said than done, okay? But we've got to manage our own emotions. So the first thing I recommend to caregivers is try to let simple mistakes slide. And it's difficult because that person in front of us is somebody we love, admire, respect. Maybe they were a remarkable employee, maybe they were a scientist, maybe they were a teacher. And it's hard to make the shift that now that person is disappearing, is vanishing. And it actually, in some ways, unconsciously, I think, makes caregivers angry. And now they're wrestling with, Mom, we want to get you in the shower. Well, I don't want to go in the shower. Okay. So sometimes you have to, let things slide, let simple mistakes slide. I think that's pretty useful. And you have to let go of the memories. This is probably the hardest thing. It was the hardest thing for me, which is accepting that patient as they are right now. I didn't want to do that. I wanted them to just stay the person they were, that person I loved and admired and wanted to be like. You really have to modify your expectations and don't treat them, and it's easy to do, as a incapable child. Mom, time to get a bath. No, I don't want to take a bath. Well, it's time to get a bath. Your voice raises, the tone starts to pierce. And this is radio personalities. People feel words. Even if you're losing your identity, you feel words. So I always say, whenever possible, try to start out with a compliment. And whenever possible, as you're trying to get something done, a bath, a change of clothing, a feeding, a medication, use very gentle, positive prompts. One of the things I got from my father is he had this incredible knack, even when he was really pretty far along, he just automatically complimented anybody he met. And thank goodness some of that fell over to my ears. So I guess for caregivers, just remember that this isn't the person they used to be. You want to use prompts, avoid sharp words or language that can be hurtful. We see the ad on TV now of an agitated older woman, and her daughter's trying to give her some medicine, and it's just going wrong real fast. The other part is, can you redirect them? Can you do reminiscence therapy? Well, before we have a bath, tell me about when you were dating Pop, okay? Can you use music therapy, aromatherapy? I'll throw all this back to the very broad shoulders of the Alzheimer's Association. They can hardly wait to meet caregivers that they can educate in groups. People can brainstorm. This works for me. Maybe it'll work for you. They're absolutely wonderful. And the walk's coming up, so I hope all your listeners agree to participate in the Alzheimer's walk, because we need all the funds we can get to advance research and reduce the suffering.
Well, I think all of your suggestions for caregivers are wonderful and important, because it's very hard. I know, we teach a stress self-management, and there's a picture in the textbook of a normal brain versus a brain with Alzheimer's. And that's the photo that seems to flip on the light that something is physically wrong. They're not doing these behaviors on purpose. None of this is on purpose. It is the disease that's talking.
What a great way to put it, Carol. Fantastic. Absolutely. And the disease is talking, and as time passes, it gets louder, takes more and more control. And, this stuns a lot of people. Alzheimer's dementia, I think, is now the fourth leading cause of death in this country. And you say, well, how can memory loss cause death? Well, you forget how to swallow. You forget how to move. So now you get god-awful bed sores, okay? you don't move because you might fall. So now you get pneumonia. So Alzheimer's dementia, it's just a cruel, cruel illness. Um,
So,
but good news, there is good news.
okay, share good news. All right, good news.
Well, the good news is, so I was a lucky guy from 2005 to 2020 that I had a half-time job in clinical research. And during that time, our site did a lot of dementia trials, as did the rest of the country, the rest of the world. There were 400 trials done, and in 2015, 2020, all 400 had failed. So there was a great demoralization, but the scientists put on their thinking caps. They got back to work. The reason they failed is most of these patients that we were treating, trying to effect a change, we were treating them way too late in the ball game. We didn't have the tools we have now. We didn't have the biomarkers. We didn't have the imaging. Now we have those. So the studies that are going forward now, we're trying to treat people at the very first blush of this illness and try to get ahead of it. We have medicines that reduce one of the culprits. It's a protein called amyloid. We've got another medicine that's in development, hasn't been rolled out yet. It treats the other culprit, which is called tau. So these two proteins, amyloid kind of covers the brain first, and then tau jumps on top of it. They block signals in the brain in all the messaging centers of their brain, and that's where people lose their memory, forget how to eat, how to wash, how to toilet. I mean, all the basics of life just kind of vanish. And then they're very, very helpless. So new medicines, new biomarkers, new excitement. This is a global epidemic. I think about China all the time. 450 million souls, and a third of that are 65 and older. How do they care for that population that's is almost as big as our country? I have no idea. We don't know how they care. I presume through the family, but I don't know about medicines, treatments. You know, there needs to be a united front there. But great excitement now, new medicines, new biomarkers. We know this is a global epidemic because we're all living longer because we have better medicine, you know, cleaner food, cleaner water, vaccines. So we're all living longer, and as we live longer, we're going to be more exposed to this dreadful illness.
Now let's take just a minute and talk about something you're going to be presenting on in a few weeks, and that's loneliness, a real killer for older people.
So in medical school, I don't believe I ever heard of that as a illness or a condition, although it's cropped up, thank goodness, which is such a contrast because here we are better connected than we've ever been, yet we're also more isolated and lonely than we've ever been. So the long and short of it is, especially as we get older, things dramatically change. You know, I'll never forget seeing an elderly man. He came in the office. He was angry. He started immediately, said, "All my friends have died. You know what that means?" And I was kind of taken back on my heels. I said, "No, sir." He said, "That means I got to get younger friends." And I thought, this fellow's a genius. He's absolutely a genius. But as we age, our friends pass away. I'm 74. I go to far more funerals now than I do weddings. As we age, we start to lose maybe our core group of folks. We start to lose our energy, our ability to do what we used to do. We lose our spouse of 50, 60 years, almost unimaginable. Maybe our adult children now live several states away, or maybe they live in the same city, but they don't come over very much because they're busy. They're trying to make their way in the world. Even in facilities, you know, assisted living, independent living, there's still a quality of loneliness. And you know, the social scientists have begun to study it. There's a fellow at the University of Chicago, John Chipio, and he likened the physical effects of loneliness, physical effects, to that of smoking 15 cigarettes a day.
Wow. I'm going to have to stop you right there. we're flat out of time.
Oh,
It's a lot of cigarettes. Thank you, Dr. Thomas Weiss. For Carol Zernial, I'm Ron Aaron. We'll pick loneliness up in a new program coming your way for Caregiver SOS On Air.
The executive producer for Caregiver SOS On Air is Daniel Calderon. The producer is Sharice Pendleton. And the associate producer is Catherine Oglesby. We'll see you next week on Caregiver SOS On Air.
You've been listening to Caregiver SOS On Air, an exclusive presentation of the WellMed Charitable Foundation. We welcome emails with suggestions and comments on this program at radio@wellmed.net. Join co-hosts Carol Zernial and Ron Aaron next week for more on caregiving, improving the health and well-being of caregivers and their care recipients everywhere. For more on caregiving and podcasts of our programs, visit caregiversos.org.